while we find the slides. So while we find the slides, it's a pleasure to be here. I was just thinking about how got involved in this work as a fellow in trying to find a sort of glutamatergic solution to negative symptoms in schizophrenia. And was talking to Ed and met Jed at that time, and found that an animal paper, a rat paper was published showing that nicotine enhanced glutamatergic transmission, and wondered if that was something that was involved in improving negative symptoms. So I thought, well, we'll do a smoking cessation trial, because we had my same 1 week first week as a fellow, we had one person come in to, that's not mine.
Oh, yes, all right, there we go. Well, at least we're
We had one
somewhere.
guy come in, age 40, pulling oxygen because he needed that to breathe at that point because emphysema was so bad. And another person died of sudden death at age 40. He was a 3-pack-a-day smoker. So I thought, well, look, what we'll do is we'll look at the effect of nicotine on negative symptoms, but we'll do smoking cessation studies. And we'll look and see if those who are on placebo get worse in terms of their negative symptoms. Thanks. And the trouble was, we did 3 studies in a row, and we couldn't get people to quit on placebo. So we couldn't see if their negative symptoms worsened on placebo. But we got started with lots of smoking cessation studies in this population, people with serious mental illness, so schizophrenia, bipolar disorder, and recurrent major depressive disorder. So it's a public health crisis. We in this room all know that those in the general population smoke. We can't get that number down low enough, but it's a lot lower than those with bipolar disorder or schizophrenia. Mortality is a shocking, it's a generation, and it's growing. And we know that we have opportunities to save lives. So this is something that we know. But this is the first slide of an academic detailing talk that we're doing as part of a Picori trial, a $10 million pragmatic trial to try to improve evidence-based treatment for people with serious mental illness in primary care. Now, we've seen the data that the smoking rates are just stable in those with serious mental illness, where they have gone down decade by decade, not fast enough in the general population, but they've trended down. And a lot of people that I speak with take that to mean that people with schizophrenia or serious mental illness can't quit smoking. But I've always had the hunch that maybe they aren't offered effective treatments. And I saw by hard luck that without treatment, these folks aren't able to quit. So I wrote this clinical trial, and without the data, these are the baseline data that we collected after we got the trial, the grant from Picori. In this project, we enrolled not just smokers who wanted to quit. This is every smoker with serious mental illness in Greater Boston who received psychiatric rehabilitation services from the 2 biggest providers. So there were about 1,300 who were potentially eligible. And we enrolled almost 90% of those folks, so 1,166. And we surveyed them, and the idea is that we're going to survey them annually for 3 years. We're in the 3rd year now, to see if our intervention will improve provision of care. And as you can see, there's plenty of room for improvement. So 2/3 of these folks had not received advice to quit. Those who had received advice to quit from their primary care doctor or their psychiatrist, the vast majority were offered a patch. And the most effective treatment out there, varenicline, 2% had been offered varenicline. And then a strange 3% had been offered varenicline plus NRT. So a lot of room to move here. But just to let you know the study design here, so this is a study where we go in and we try to offer academic detailing. And this is a teaching technique that's promoted by NARCAD, which is based at the Brigham in Boston, the National Resource Center for Academic Detailing. Essentially, it's you go in and you teach with the goal of changing behavior, of identifying misconceptions, stereotypes, stigma, and changing behavior, modeled on pharmaceutical industry detailing. So our goal was to cluster randomize primary care clinics treating these patients. So the patients were enrolled first, and then their clinics became enrolled. So 2/3 of the clinics would be given detailing to the providers, and then the patients treated by those providers would be randomized at the patient level to either receive a community health worker support or not. And that support was to the doc and to the provider. So I mainly want to share with you the case that I'm making in the detailing to the doctors, because it outlines, I think, something that these patients need treatment more than anybody, and that it does ameliorate some of these negative affects, some of this psychic pain that patients with serious mental illness have, and certainly, I think, have exacerbated during a quit attempt. So this is the first slide to the docs, motivational, right? Good news for patients who smoke, how we can help people with and without serious mental illness quit smoking, because really the recommendations are the same. And so we start right off the bat with data from the Eagles trial, because safety, I think, is the key. These docs are trying to do the best by their patients, but in the end, they seem to overemphasize the risk of treatment and underappreciate the benefits of treatment in these patients. So we start with the non-psychiatric cohort in the Eagles trial, so nearly 4,000 smokers from 144 countries, that the average risk is about 2% for a moderate to severe neuropsychiatric adverse event. And this was defined largely by the FDA with some input from the EMA on this bin of moderate to severe neuropsychiatric adverse events. So it's really a catch-all to improve power. And the goal, this trial was designed to estimate the incidence of AEs, of neuropsychiatric AEs, with treatment. So then I show the subset with psychotic disorders. So this wasn't published in the Lancet paper. We published this earlier this year in the Journal of Clinical Psychopharmacology, where we pull out specific psychiatric illnesses, because as treaters, we don't treat somebody with a psychiatric illness. We treat somebody with a psychotic disorder, a mood disorder, anxiety disorder. So amongst those with psychotic disorders, they're threefold more likely to have an AE during a quit attempt than those without a psychiatric illness, so not shocking. But what is surprising is there's no difference in whether you give them placebo, bupropion, or varenicline, right? So there's no difference by treatment. What is different that I'll show you is these folks are much more likely to quit. And then for mood disorders, it's the same story. In this mood disorders category, the way the study was randomized, these are stratified, and this mood disorders component or subcohort included those with bipolar disorder, right? So no impact of treatment on AEs. And the estimation, and that's quite good, is about 2% of those who try to quit smoking who don't have a prior psychiatric illness will experience a moderate to severe neuropsychiatric adverse event during their smoking cessation attempt. So that's during the 12 weeks of treatment plus 4 weeks of follow-up. So over 16 weeks, they'll have a moderate to severe neuropsychiatric adverse event independent of treatment. Because remember, the goal of this talk is to encourage treaters to treat these patients. And then in those with a psychiatric illness, they have about a 6% chance of a neuropsychiatric adverse event. Again, independent of treatment. These are usually, these are moderate to severe. Now, if you take a step back and think about some of the other talks today and look at these data, if you include mild neuropsychiatric adverse event, the rate goes up to 21% in the psychotic disorders group and 41% in the mood disorders and the anxiety disorders group, right? So many people, bucket them together. It's about a third of the patients had a mild neuropsychiatric adverse event during 16 weeks of treatment and follow-up. So they certainly are having perturbations, but they're not reaching the level of any kind of functional impairment, and we only had about 2% stop treatment. Importantly, there were no patterns of super worrisome neuropsychiatric adverse events, which were in the boxed warning and really inhibited treatment of these patients. And so here's where there's a big difference, right? So the AEs are flat, but the abstinence rates are not. And so think about it. If in the psychotic disorders group, if you're sevenfold more likely to quit or sixfold more likely to quit with varenicline than placebo, but your AE rate was the same. It's pretty interesting, right? Because certainly in the AE rate are nicotine withdrawal symptoms built in, right? So these two cohorts were just published. This is just in press, so you won't have seen it. This is the bipolar subcohort, so much smaller, pulled out from the mood disorder subcohort. And so this is for efficacy. Interestingly, there's really nothing happening in the NRT and the bupropion arms. And the relapse rate is quite high from during treatment to the 6-month follow-up, which is something we see in psychotic disorders as well. Safety, there's no statistically significant difference amongst these, but you're seeing higher AE rate in the bipolar subcohort than in the psychiatric subcohort altogether. So there's more lability, and they may have more trouble with the smoking cessation tip. So they have about a 10% chance of some sort of moderate to severe neuropsychiatric adverse event during a cessation attempt. So essentially, the efficacy results is a confirmatory finding, sort of strengthening our conclusions. And I want to go back and just point this out. The 4% abstinence rate on placebo, we've seen that in study after study. That's what I saw in my trials. If you go into the Cochrane Review for Smoking Cessation and Schizophrenia and do the math, that's about the placebo quit rates, a 4% quit rate. So this group of people will not quit without a medication, right? There's basically no hope. And in our studies, we're giving sort of Cadillac behavioral treatment, and they come. So they're getting the dosing. So we have over an 80% show rate over 12 weeks for a 1-hour CBT group treatment program, right, which I think is what bumps our cessation rates in our med groups, because we have 30 to 50% abstinence rates in our schizophrenia samples during treatment, but we're still at 4% in this group, which begs the question of whether they're dropping out due to AEs when they're not on meds. So I'll go through these a little bit quickly, but so this is for the docs to try to challenge some of their preconceived notions that we found out in focus groups. People with SMI don't want to quit smoking. In fact, the same percentage of those with SMI want to quit as in the general population. Quitting worsens psychiatric symptoms. So this is where I quote the Taylor paper that Dave Gilbert referenced. So stopping smoking is associated with reduced depressive symptoms, anxiety symptoms, and stress in those who quit compared to those who don't. Now, there may be something where those who start to have symptoms don't go on to stay quit, which is certainly an issue. We certainly, though, don't see worsening of psychiatric symptoms in study after study in treated patients who quit. Meds don't help those with SMI quit smoking. In fact, they may help them even more to quit smoking. The odds ratios are higher, sort of 3 to 6-fold compared to placebo in those with SMI. And then this has been the key piece. This flexible quit and gradual quit that came out in the prescribing guidelines have helped, I think, move the needle in getting treatment delivered more than anything else. And I'll speak about that here. So this works in our studies, and it works to get docs to help people quit. So we've always used this flexible quit approach where we start the med and we watch the patient for about 3 weeks, 4 weeks, make sure they're stable on their medication. We handle any AEs from their meds, and then we ask them to quit smoking. So we don't have patients or the staff conflating nicotine withdrawal symptoms with intolerance of the medication. And so when I tell primary care docs that that's what they can do, they don't have to talk the patient into quitting, right, in that visit, which they don't want to try to do because it's going to mess up their schedule because the patient's not going to want to. They can just advise the person to quit and write a prescription and then see them back in a month or have their nurse see them back in a month and set a quit date then. That's gotten movement in patients or in the doc's ability or willingness to prescribe. So these all work now. The docs have to assess smoking cessation. If they have an electronic medical record, that's often a page that they have to fill out before they can get on to write their note. It's reasonably easy to have docs remind patients that quitting is important to do for their health. Not to ask if you want to quit, but to tell the person that they recommend they quit, and then to write a prescription and see them back. So the dosing is the same for those with serious mental illness as without. We recommend dual NRT really as a first line, and then bupropion. So how long to treat? We have no idea, right? I mean, this is from a JAMA paper in 2014 that we did, mainly motivated by one of my patients who had been in 2 of our smoking cessation trials, one with bupropion and one with bupropion plus dual NRT. He quit both times, and both times within 2 weeks of stopping the medicine, he relapsed. And we saw that time and time again. And so we wrote this grant to NIDA back when Ivan Montoya was acting director the time before of the treatment branch, and we recommended, we proposed bupropion plus dual NRT because we wanted to get the best quit rates during an open label phase that we could, so that just for the economics, because we needed to randomize once people were abstinent. But when this one guy came in, he walked past my office one day in the schizophrenia clinic, and he did a double take. And when he saw me, and he came back and he says, "Dr. Evins, I forgot to smoke today." And it was about lunchtime. And this was a 3-pack-a-day smoker. His mom smoked, his brother smoked, everybody. And I was like, "Well, what do you think it is?" "Oh, well, Dr. Goff, who was my boss at the time, put me on that new medicine, that Chantrix medicine." And I thought, because I knew how, I had worked with Robert a few times. And so we actually changed the grant to put it in as varenicline, and that's how we did this study. And we got we randomized about 250 smokers we enrolled 250 smokers to open label varenicline, and I'll show you some of the depression data from that part of the trial in a minute. But amongst those who quit, we then randomized them to stay on varenicline or switch to identical placebo and continue behavioral treatment. So the people got behavioral treatment throughout. They got it weekly for a month, bi-weekly for a month, and then monthly for the balance of a year. So this goes out to 52 weeks. And here you go. When you get the tire kickers out, these are people who were abstinent. The average duration of abstinence at the time of randomization was 42 days. So they'd been quit for a while. They still fell off a cliff here. The median time to relapse amongst placebo-treated patients was 35 days, and the median time to relapse amongst those who stayed on varenicline was 358 days. But here, we took this out to this is 64 weeks, and we even went out to 75 weeks following people. The groups remained different, but they were converging. So at 75 weeks, they were closer together. They were still statistically significantly different, but the relapse rate was growing off meds. So I'm really not able to say what's the optimal duration of treatment. Clearly, 12 weeks isn't enough for these folks, and I don't know about here. Interestingly, based on these data, Mass Health, or the Medicaid benefit in Massachusetts, now covers varenicline treatment for a year in people with serious mental illness with a prior authorization. So that's kind of nice. But this just sort of says to me that there are multiple mechanisms governing this rapid relapse, which I'll try to unpack a little bit later. We took those data because I was interested in how those data compared to to non-psychiatrically ill smokers. So we were fortunate enough to be able to put our data set together with person-level data from Serena Tonstad's similarly designed relapse prevention study or maintenance treatment study. Serena's study only went to 24 weeks. So we analyzed these data together. Mainly I wanted to look at how severity of dependence at baseline factored into relapse. And so what we found was Amongst those randomized to placebo, right, for the maintenance phase, those with a psychiatric illness fared far worse than those without a psychiatric illness, right? Significant difference here. But amongst those who went on varenicline, controlling for baseline dependence, there's no difference in those with and without schizophrenia or bipolar disorder. It's pretty impressive to me that maintenance treatment normalized the relapse curve. Now, granted, you get all the tire kickers out, everybody's abstinent at baseline, but it just illustrated to me what a big difference treatment made for these folks. So the new treatment guidelines, consensus guidelines, are super helpful, I think, in our effort to get primary care doctors out there treating people with serious mental illness, largely because they recommend treating all smokers, regardless of stage of change. So again, recommend quitting and offering a treatment. Essentially, it's like an opt-out, rather than an opt-in approach, and it really fits with the sort of workflow for people doing primary care. These are the data that, from a paper that Corey Cather took the lead on from our open label phase from our relapse prevention study. So this is all comers. We had, I didn't include the bipolar patients in this study because it was such a small cohort. We only had 20 with bipolar. So we had about 180 people come into this study, and I wanted to look at depressive symptoms. I was really interested in whether depressive symptoms spiked right around or right after the quit date. So again, they started varenicline, and they took it for a month before their quit week, essentially. They set a quit date at week 4, and they were supposed to come in 24 hours abstinent or overnight abstinent on their week 5 visit, right? And so we looked at these data by a number of different, cutting the data different ways. In this analysis, we looked at those who quit, so those who had at least 2 weeks of abstinence by week 12, so that's the solid line. And then the bigger dash is those who did not become abstinent. And then the small dotted line is those who dropped out. And I was expecting a spike in those who dropped out, and we didn't see that. I mean, we saw no change in those who dropped out, and actually a significant reduction, although it's small, but a reduction over time in those who stayed in the trial. And so the numbers are interesting. Those who quit, we had 70 who quit, or 74 who quit. We had about 71 who dropped out, and only about 30 who stayed in the trial all the way to the bitter end and didn't quit, right? So essentially self-selection, but we were looking for some sort of reason maybe for dropout or some sort of precipitant to drop out, and did not see that here. We split the data by those who had essentially a likelihood for major depressive disorder at baseline. So this is the Calgary Depression Symptom Scale. People who had a score of 6 or greater on enrollment compared to those who had a score of less than 6. And so looking at those who were at risk for worsening of depression. And again, we saw no change in those who had low symptoms, but we didn't see that those who had high depressive symptoms at enrollment were at risk. Now maybe this is the measurement effect that David showed us. I mean, these are just people on a medication who are preparing for a quit attempt. So we had 5 measurements before the quit attempt. And then we split by and this was about a third of the sample had symptoms for depression. I mean, and also granted, about a third of these people were on an antidepressant, about 20% were on an anxiolytic, and they were all on an antipsychotic. So this is the real world. So maybe that's protective, but that's important in a real world sample. And then interestingly, so I thought, well, maybe we should look at those who've had a prior suicide attempt. They're not depressed at entry, but there certainly they'd be more at risk for depressive symptoms. And again, we did not see a spike over time. We certainly didn't see and there's no control group. Everybody was on varenicline. But so we're not seeing a rise in symptoms with the varenicline treatment or with an attempt at quitting smoking. And in these bottom two slides, we lump together those who were successful with abstinence and those who were not. So just maybe sort of food for thought. And then lastly, just wanted to throw up here a slide from a paper that I published with Jaakko Caprio from his Finnish twin study, where we looked at the data right side up, upside down, and sideways to look for an effect of smoking and smoking cessation on suicide over 35 years. And we had smoking data at 2 time points. We had suicide data throughout from the great Finnish national registries. We also had data on ever use of an antidepressant, ever use of an anxiolytic, ever on a psychiatric disability, and we were able to do analyses with and without those folks who were at high risk. And no matter how we sliced the data, we found that smoking was associated with suicide, with smoking cessation not significantly associated with suicide compared to never smokers. And this was true. Also, we did a competing risk model where we also took out people who had any kind of smoking-related illness that might be associated with taking your own life, like a cancer diagnosis, et cetera. So again, cause, effect, this is cross-sectional, but just food for thought is the data that we have, and I figured it would be nice for discussion. So that's all I have. I appreciate your time.
Time for questions, and that was fascinating as I thought it was going to be. And just a quick question, kind of, again, because you alluded to some of the baseline drift, if you want to call it that, and Dave Gilbert's findings, but did you look at anger specifically on any of the scales? Because I just remember that was one of the strongest effects in your study, and maybe that would be a clearer way of comparing.
That's a great question, Jed. So this is the Calgary Depression Scale. We also did the depression cluster from the Wisconsin withdrawal syndrome. But so there is an irritability question there, which we could go and look at. It's in the cluster. The cluster showed basically the same trends, the Wisconsin as the Calgary, but we could certainly look at that. So certainly we see that in patients, that sort of high energy, negative affect sort of
Yeah, it
dimension.
might be interesting. Look at that one item. Yeah. Questions over? Okay, we'll go down the row.
So the data is very compelling. The question in the practical terms is, how do you restructure the clinic operation so that these patients can be easily seen and processed through advanced practice providers and others, so that this kind of work can be translated into the community?
So we are looking for people on our dissemination task force that's in the last year of our Picori trial, and that's what we're going to be addressing. But to me, this change in the practice guidelines, where you should treat all smokers regardless of readiness to quit, it makes a huge difference. So anybody essentially with a prescription pad, can initiate this treatment, and then the follow-up can be done. Hopefully, I understand there's an app being tested here at Duke, which I think would be fantastic. The quit line is not readily used by our folks. I think an app might be better because there's no stranger on the other side of that app, whereas on the phone there seems to be some reticence involved. But I think that with just having the expectation be that like they would for type 2 diabetes or hypertension, you recommend a behavior change, you recommend exercise, change the salt in your diet, right? But you don't withhold the metformin until they've lost weight, right? You do it together, right?
So I'm just, as a prior family physician, time is of an essence.
That's right.
And so I'm wondering if you focused only on primary care clinics. I have this probably misperception that psychiatrists have a lot more time to spend with their patients than a family physician or an internist does.
Yeah, they actually don't. They have 15-minute visits as well, so maybe 15 minutes is long for a family doctor. So okay, if you got 7 and we've got 15, I hear you. We wanted to include psychiatrists and primary care doctors, but we couldn't because of the crazy way that care is provided in Greater Boston. We couldn't include the psychiatric clinics in the cluster randomization because you get hundreds of patients at the psych clinics and they get their primary care at dozens of clinics. So just for practical reasons, our initial design was to include both, but when we came down to doing the cluster randomization, we couldn't. But we're about to start. We've got someone who's got a SAMHSA grant in King County, Seattle, Washington. Essentially, we're gonna test this there in psychiatric clinics. Joe.
Oh no, we're back.
One question there, then Joe.
Hi. I really appreciated this lecture. I am not engaged in research. However, I am engaged in clinical care of smokers. What I do find in our patients that are coming in my setting, who do have the bipolar, who do have the schizophrenia, the depression, I find I am met with a lot of resistance on their part for taking any medication because they are so concerned with exacerbation of their symptoms. And I appreciated the show where that really doesn't happen.
That's right.
But how do you convince people
Yeah, so first
that
I
this
showed
doesn't
the
happen?
SNL video on YouTube of how taking varenicline and then like your head blows up, right? So we get that out of the way. It takes about 3 minutes, and then I actually show them the data, and I show them that 6% of the time there's a problem, but it doesn't matter which medicine you're on, right? So and I'll tell them that my boss, fantastic Don Goff, I really respect him. He called me up to tell me I needed to take one of the patients off of study medicine who was in my varenicline trial randomized phase because she got more psychotic. It turned out she was on placebo. So we don't use placebo in clinical practice. Patients don't try very often, but they're 4 or 5 times more likely to succeed. And you can stop it at any time. These aren't permanent changes. So let's give it a try. And separating trying the medicine from the quit date, so you don't. It makes a big difference because I can't tell you the number of times I started meds and 5 weeks later on the quit date, doc, this medicine's causing a headache for me. And I'm thinking, it's probably not the medicine. Let's give this a few days. This is probably a nicotine withdrawal symptom. So separating the starting of the medicine from the quit date, I think gives huge clarity to you as the provider and the patient.
So just can I ask a quick follow-up to that? Because I was wondering when you gave that, let's say 5 to 7% moderate or more adverse event, it's the same across all medications, but everybody has quit smoking, so it could be an adverse event to quitting, i.e. withdrawal. But what would be the expected rate of adverse events in any 16-week period other than a quitting period? Do you have comparable data like?
Nope. I
No.
wanted that as part
Yeah.
of the trial. We don't have that. So that's right. So if you figure that the base rate is these are all psychiatric symptoms except for craving, right? These are all symptoms that are common in their illness. So that's probably, it's surely some proportion of that AE rate.
But I wonder, Joe.
Eden, thanks. Just so much great work. One thing I didn't hear you talk about was medication adherence. And I wonder, we know that even under the ideal conditions, like a clinical trial, adherence is not great. In actual practice, we know it's abysmal. And I wonder if you could talk a little bit about whether psychiatric illness is associated with worse adherence. Looks like you're flipping back to data that I missed.
No, you didn't miss anything.
Okay,
Just
good.
to illustrate.
But I also, I wonder if there's a relationship between psychiatric illness and adherence rates, and whether we know anything about the relationship between adherence and treatment outcomes in these patient populations.
So
And
we
then,
know nothing. We know
Yeah,
nothing.
right.
And it would be fantastic that there are now these great sort of Tony knows the name of this. These great companies that can sort of video you taking your medicine, but blur the face, but recognize it. So I would love to see that. I will tell you that 95% of the people on the psychotic disorders group in the Eagles trial were on an antipsychotic, and on average they were on 4 meds. Half of the people in the mood disorders group were on a medicine.
Yep.
So on the one hand, I mean, I find it's a little easier to get my psychotic patients to take a smoking cessation medicine because they're used to taking a medicine.
Right.
So it's counterintuitive, whereas the anxiety and mood disorder patients who are not on a medicine are a little more wary. But if I say, look, this will triple your chance of success, you put a lot of work into this quit attempt, don't you want a greater chance of success? And in the way you're trading a medicine for this other compound, or 150, 1,000, 900 compounds that you're putting in your body. So,
Yeah.
but I would love to see, because I wonder how these rates would change with better adherence. On the other hand, this is what you can expect. I mean, these are people who showed up wanting to quit. In our Picori trial, it's just all smokers, so the numbers are going to be way different.
Yeah. Are you? Do you have measures of adherence in that study, in the Picori study?
No.
No,
I mean,
which is so unfortunate because there's so little we know about. We don't know that much about adherence rates. We don't know about differential adherence rates. We don't know about predictors of it or correlates of it.
It's something. It's expensive. This company that we it's expensive, but it's doable, and so I think it's worth writing into NIH grants because it improves essentially the reliability and reproducibility, the sort of rigor of the data.
Yeah.
So certainly for testing new treatments, but also for testing efficacy of available treatments to try to refine risk-benefit ratios. Right.
Yep. Great.
All right, well, thanks again. We'll have more time for discussion too.